Hello, it's a pleasure to be here. I'll be discussing the connection between hypermobility and long COVID. The definition of long COVID has evolved over the past 5 years. In June of 2024, NASEM, the National Academies of Science, Engineering, and Medicine, created a definition of long COVID as an infection-associated chronic condition following SARS-CoV-2 infection that lasts for at least 3 months, affects at least one organ system, and can be continuous, relapsing, remitting, or progressive. The burden of limited recovery from COVID-19 presents a significant clinical challenge, with an estimated 5.3% of U.S. adults currently experiencing long COVID. The projected economic impact of long COVID ranges from $140 to $600 billion annually. Long COVID impacts multiple organ systems, and over 200 symptoms have been reported in the literature. The most common symptoms listed in order of frequency are fatigue, difficulty concentrating, muscle aches and pains, and shortness of breath. Other symptoms include bloating, constipation, diarrhea, altered taste and smell, recurring headaches, sleep disturbance, lightheadedness, orthostatic intolerance, or tachycardia. The presentation of long COVID is heterogeneous, and these distinct profiles require further characterization to design personalized care and target effective treatment. In an electronic health record study of over 20,000 people with long COVID in Florida, using artificial intelligence, subgroups of patients with different organ systems affected by long COVID were identified. These subgroups included cardiac and renal in 34%, respiratory, sleep, and anxiety in 33%, musculoskeletal and nervous in 23%, and digestive and respiratory in 10%. A consistent finding across multiple studies was that long COVID is more likely to occur in middle-aged and female patients. CDC assessments also estimate that long COVID has a disproportionate impact on transgender, Hispanic, and multiracial populations. In addition, the likelihood of developing long COVID appears to be increased by the presence of pre-existing activity-limiting health conditions or disabilities. Fibromyalgia, irritable bowel syndrome, migraine headache, anxiety, depression, endometriosis, and back pain are among a number of conditions identified as raising the risk of long COVID. Other studies have failed to show specific associations, particularly in relation to pre-existing affective disorders. The role of latent viruses is also increasingly appreciated in the development of conditions such as myalgic encephalomyelitis chronic fatigue syndrome, or MECFS. Long COVID research reveals high rates of postural orthostatic tachycardia syndrome, or POTS, generalized joint hypermobility, hypermobile Ehlers-Danlos syndrome, or EDS, and hypermobility spectrum disorders, or HSD. These conditions are also highly comorbid with each other. POTS is a chronic and often dislabeling condition characterized by orthostatic intolerance with an excessive increase in heart rate without hypotension during upright posture. POTS is considered to be a major subphenotype of long COVID, with an estimated prevalence of 30 to 75%. MECFS, POTS, hypermobility spectrum disorder, and hypermobile Ehlers-Danlos syndrome are archetypes of seemingly complex, poorly understood multisystem illnesses. Dysautonomia is frequently identified in patients with hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. Also, the constellation of symptoms and comorbidities in long COVID are similar to those found in MECFS, POTS, and EDS and hypermobility spectrum disorders. Hypermobile Ehlers-Danlos syndrome, and to a lesser extent hypermobility spectrum disorder, may also be associated with other extra-articular symptoms, including orthostatic intolerance, anxiety disorders, chronic pain, fatigue, functional gastrointestinal disorders, and pelvic and bladder dysfunction. They are the most common joint hypermobility conditions encountered by physicians. In 2017, the International Classification of Ehlers-Danlos syndromes was introduced to replace previous terms used to describe symptomatic joint hypermobility. The prevalence of hypermobile Ehlers-Danlos syndrome is approximately 1 in 5,000 births, and in conjunction with classical Ehlers-Danlos syndrome, accounts for 90% or more of cases of Ehlers-Danlos syndrome. Clinical features of hypermobile EDS include joint hypermobility, joint pain, musculoskeletal complications, skin elasticity, and recurrent joint dislocations. Hypermobility spectrum disorders were introduced to represent patients who do not meet the diagnostic criteria for hypermobile EDS and occur in about 10 to 20% of the general population, with a higher prevalence in children and adolescents. There is growing interest in how variant connective tissue, often recognized by the presence of generalized joint hypermobility, may represent a common constitutional factor predisposing to hereditary disorders of connective tissue, which compromise a matrix of proteins that include collagen, elastin, fibrillin, and tenacin. A recent study of chronic pain and fatigue, such as fibromyalgia and ME/CFS, observed that 81% had symptomatic joint hypermobility, and less than 25% of these patients had previously been diagnosed with these conditions. Joint hypermobility is typically more common in children, adolescents, Asians, Western Africans, and females, and declines with age. Generalized joint hypermobility has an estimated prevalence of around 3%. The range is between 2 to 65% based on the study, and is suspected to be underdiagnosed in the general population. Our group performed a questionnaire study to determine new or worsening comorbidities and conditions occurring in patients who had confirmed infection and developed long COVID, and compared those to patients without long COVID. New or worsening conditions were reported with significantly higher frequency across all surveyed systems in patients with long COVID compared to controls, particularly in the arenas of pain, neurological, sleep, and skin disorders, as well as allergies, sensitivities, and intolerances. Within a miscellaneous category, long COVID patients reported significantly higher rates of clinician-suspected or diagnosed conditions compared to controls. There was a significantly higher prevalence of mast cell issues, viral reactivation, mitochondrial dysfunction, endothelial dysfunction, and vascular compression syndromes in the long COVID group compared to controls. Our study also embedded screening criteria within the questionnaires to determine whether patients met criteria for ME/CFS, generalized joint hypermobility, or orthostatic intolerance. The IOM-NASM 2015 ME/CFS criteria, 5-part hypermobility self-assessment questionnaire, and composite autonomic symptom scale were used to assess for these conditions. The long COVID patients in our study had statistically significant rates of ME/CFS, generalized joint hypermobility, and orthostatic intolerance, even in those not previously diagnosed with these conditions. A large population-based study from the UK investigated the association between generalized joint hypermobility and recovery from COVID-19 in a sample of 2,854 patients who reported at least one infection from COVID-19. Generalized joint hypermobility was determined using the 5-part self-report questionnaire, where a score of 2 or more indicates generalized joint hypermobility. Of the patients who had not recovered fully from COVID-19 infection, 29.4% had generalized joint hypermobility, and in the fully recovered group, 22.6% had generalized joint hypermobility. Generalized joint hypermobility was significantly associated with not having recovered from COVID-19, even when adjusted for a number of demographic factors. This observation is clinically important in identifying the subphenotypes of long COVID. Eccles demonstrated that fatigue acts as a mediator in the relationship between generalized joint hypermobility and non-recovery from COVID-19, using the Chalder fatigue scale to quantify fatigue. Adjusting for all covariates, generalized joint hypermobility significantly predicted higher fatigue levels, which suggests that fatigue levels affect the likelihood of non-recovery and implies that generalized joint hypermobility is a subtype of long COVID, with fatigue being the central feature. The pathophysiology of long COVID associated with ME/CFS, hypermobility, and dysautonomia is currently poorly understood. Convergent biological mechanisms, dysregulated autonomic, inflammatory, and metabolic processes are all increasingly implicated in the expression and maintenance of long COVID. Hypermobility conditions are associated with chronic cell-mediated inflammation, resulting in a pro-inflammatory cytokine and chemokine environment in the cellular matrix. The pathophysiologic mechanisms of dysautonomia, common in both hypermobility and long COVID, are often driven by a hyperadrenergic state. Adrenaline, which is elevated in hyperadrenergic POTS, inhibits the function of human fibroblasts and modulates the expression of local growth factors, thereby potentially explaining a mechanism of adrenaline-induced connective tissue dysfunction. Ongoing inflammatory processes in long COVID may involve mast cell activation and degranulation, initiating pro-inflammatory cytokine cascades, leading to hyperinflammation within the connective tissue and connective tissue breakdown. Hence, hyperactivation of mast cells is a likely mechanism that links long COVID, hypermobile Ehlers-Danlos syndrome, hypermobility spectrum disorders, myalgic encephalomyelitis, chronic fatigue syndrome, and postural orthostatic tachycardia syndrome. Mast cells can be activated by SARS-CoV-2 because they express receptors for viral entry, including H1, ACE2, TMPRSS2, NRP1, integrins, and cathepsins. They promote pro-inflammatory T helper responses and toll-like receptor 4-induced interleukin-1 beta, found to be elevated in long COVID patients. In patients with hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder, mast cell hyperactivation is observed when they respond to defective connective tissue and promote the breakdown of extracellular matrix and connective tissue. Mast cell numbers and functions differ by sex and genetic background, which may partially explain the frequency of long COVID, ME/CFS, and hypermobility disorders in white females. Viral infections, including SARS-CoV-2, are known to localize to mitochondria and utilize mitochondrial machinery for viral replication, which could lead to mitochondrial dysfunction in numerous cell types and organs. It has definitely been shown to be a component of post-exertional malaise in the muscle tissue of patients with long COVID, and is linked to chronic fatigue, a hallmark symptom of both ME/CFS and long COVID. In addition, mitochondrial dysfunction likely plays a role in the connection between hypermobility and long COVID. Genetic factors are thought to contribute to mitochondrial dysfunction. C677T or A1298C polymorphisms in the MTHFR gene, which may occur in up to 35% of the population, have been proposed to link to hypermobility spectrum disorder by a decreased methylation of the matrix metalloprotease 2 gene and increased cleavage of the proteoglycan decorin. MTHFR mutations have also been associated with impaired activity of the mitochondrial respiratory chain, which may drive both hypermobility and fatigue with post-exertional malaise. Connective tissue laxity is inherent in hypermobility conditions and can contribute to impaired structural integrity of blood vessels, venous pooling, and subsequent orthostatic intolerance in long COVID. If this tissue laxity is worsened by inflammation, this may contribute to structural and vascular instability. Patients with hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders frequently exhibit signs of altered baroreflex sensitivity and increased sympathetic activity, which can impair normal autonomic responses to postural and environmental changes. Vascular compression syndromes and cerebral venous outflow disorders have a high co-occurrence in connective tissue disorders, especially Ehlers-Danlos syndrome. So hypermobility is common in patients with long COVID, POTS, ME/CFS, and fibromyalgia. Patients with hypermobility disorders often experience fatigue similar to ME/CFS and fibromyalgia. Many individuals with long COVID also report symptoms overlapping fatigue, cognitive issues, autonomic symptoms, orthostatic intolerance, similar to patients with hypermobility. Emerging evidence suggests that pre-existing hypermobility or connective tissue vulnerabilities may predispose some individuals to develop long COVID. The overlap of symptoms suggests potential shared pathophysiology, and including the connective tissue fragility affecting vascular and autonomic stability. Recognizing hypermobility and Ehlers-Danlos in patients with long COVID is important, as it may influence symptom outcomes and management as well as prognosis. Just a quick word about management. When it comes to management strategies, treat the predominant symptoms. For example, mineralocorticoids, alpha agonists, and beta blockers may be beneficial to manage POTS. Low-dose naltrexone may be helpful for many chronic conditions associated with long COVID. Mast cell therapies and management of endothelial dysfunction through diet and physical activity have been associated with symptom improvement in long COVID. Lastly, there's no therapeutic role for the use of opioid therapy, which can actually be detrimental to patients. Long COVID stands as a prominent recent example of how an infectious agent can be associated with chronic disease. Our research demonstrates statistically significant reporting of new diagnoses or worsening of existing conditions following COVID-19 infection, present across almost every organ system surveyed in long COVID compared to controls. Notably, long COVID patients were more likely to screen positive for myalgic encephalomyelitis, chronic fatigue syndrome, orthostatic intolerance, or generalized joint hypermobility than to report being formally diagnosed with one of these conditions. Individuals with generalized joint hypermobility were approximately 30% more likely to not have recovered from initial COVID-19 infection, and this is linked through the fatigue level. Generalized joint hypermobility is likely a constitutional feature predisposing to a number of multi-systems features, and they may represent a subtype of those with persistent symptoms from COVID-19. Given the strong relationship between hypermobility and chronic fatigue with post-exertional malaise, and the significant overlap between hypermobility spectrum disorder and other complex chronic medical conditions such as POTS, long COVID, fibromyalgia, and ME/CFS, screening for hypermobility and other related conditions is critical, and patients should be enrolled into multidisciplinary treatment teams to provide individualized treatment to help with maximizing function. Thank you.